I believe, that talks about primary bone healing. So what we're concerned about here is we discussed fractures yesterday and how to describe fractures and the types of fractures and different definitions of fractures. But now we're going to talk just a little bit about, and very quickly, about how those fractures can heal. And basically, a fracture can heal one of two ways. One's better than the other. So one way is primary bone healing. And as you would anticipate, the other way is secondary bone healing. Primary bone healing is the ideal, the best way for a fracture to heal, although it's usually not the most common way. So what is primary bone healing is if you have two fracture fragments that are adjacent to each other and they're actually touching each other. Primary bone healing occurs without the formation of a callus. And it's a direct result of, if you remember back to anatomy and histo, it's a direct result to the extension of the Haversian system, the Haversian canals across the fracture and into the other side of the bone, the other side of the fracture fragment. And that results in direct bony formation that occurs in the bone itself, in the marrow cavity, in the cortex, but without a callus. And primary bone healing can only occur with certain parameters that are intact. And the main one is that the two fracture gaps have to be, there can't be a gap between the fractures, the fracture fragments. They have to be touching each other and they have to be rigidly fixed. So they can't be moving at all. So you can't have, if I have two fracture fragments like this, they have to be touching each other for primary bone healing. If they're like this, it's never going to happen. Okay. You might get secondary bone healing, which we're going to talk about in a minute, but never primary. So they got to be touching each other and then they can't be moving. So you can't have any even micro motion of those fractures. They have to be perfectly fixed and still for primary bone healing to occur. So they can't be doing this. They can't be doing this. They can't be doing this. Okay. They have to be constantly, no matter if the animal's walking around, they have to be like that. Okay. So they can't be moving at all, and they have to be touching each other for primary bone healing to occur. So the key is no callus formation. The bone just magically heals, and usually it will do it relatively quickly. Okay, so that's primary bone healing. Unfortunately, that's not the way it happens a lot of times. So lack of a callus, gradual loss of opacity of the fracture that you can see, there's that radiolucent fracture line over time just disappears. Okay, here's an example of primary bone healing. This is a fracture. You can see it's mildly comminuted in the mid diaphyseal portion of this femur. This is a device that is used surgically called an interlocking nail. And that device, it's different than just putting a Steinmann pin down the middle of the marrow cavity. That nail actually has screw holes here, here, and here, and here. And so the fact that we put the pin down the middle of the marrow cavity and then we secure it with two bolts up here, two bolts down in here, that will prevent those fracture fragments from moving around. Okay. And if you look here, this is a little bit of time later, but it basically this fracture is now healed. There's little to no callus formation. You can still make out the fracture line, but it's super, super indistinct. The fracture appears to have healed in anatomic alignment. So that's a good example of primary bone healing. The other type of fracture healing is secondary bone healing. This is the one that is more common, but it's not as ideal. And in secondary bone healing, you do get callus formation. So basically, it's a fracture that is comminuted. There's usually a fracture gap or something else that's going on in that fracture area, which we're going to talk about in the next little part about things that influence fracture healing. Okay, but there's something else going on. There may be motion, there may be an infection, things like that, that will not allow for primary bone healing, but secondary bone healing can then occur. Okay, so with secondary bone healing, the first thing is you have a fracture, and immediately, as soon as you have a fracture of a bone, you typically get a little bit of blood around it and a blood clot that starts to form around the fracture fragments. Okay, well, obviously a blood clot around there isn't going to stabilize anything. But before too long, after a few days, that blood clot will kind of start to harden and it kind of turns into some fibrous tissue. And then you start to get a little bit of fibrous tissue around the callus. And the fibrous tissue is a little bit more rigid. It's a little bit more sturdy than just a blood clot. And that fibrous tissue will act to stabilize the fracture fragments a little bit. If the dog goes running around outside the backyard, it's just going to break off the fibrous fragments also around the fracture, and then you have to start all over. Okay. After a while, just like we said that with dystrophic mineralization, one of the body's attempt to try to heal things is it turns it into mineralized tissue. It turns it into bone. So after a while, that fibrous tissue will remodel and tend to mineralize and turn into bone. And that's what you see when you're seeing a callus, is mineralization of that fibrous tissue around a fracture. And given time, hopefully, that callus will extend and bridge the fracture gap. And over time, it will be circumferentially bridging the fracture gap, and that will stabilize the fracture. Over time, then, if the animal has limited exercise and isn't crazy, then that fracture, that callus formation itself will become pretty big, but over time, it will remodel and become smaller and smaller. Okay, so that's secondary bone healing. So primary bone healing, you get no callus, but it can only happen if the fracture fragments are adjacent to each other and they don't move. Okay, secondary bone healing is an attempt by the body to heal a fracture that is anything besides just fracture fragments right next to each other. Secondary bone healing is more common, but it's not as ideal. Okay, so here's an example of secondary bone healing. So I see here's a transverse fracture of the radius and ulna here. That's right when it happened. And over time, you can see now we get this callus formation. So this would happen if a dog, if you just decided I'm going to splint the dog, you know, I'm not going to, the owners or whatever reason don't want to pay to have it fixed like it should be, or you don't have the ability to do that, then you put the dog in a cage and you put a splint on it and try to keep it from using the leg as much as you can. So we can see now there's this large callus formation that's starting to form here and starting to form here. There's some over here, there's a little bit over here, and same with the ulna. But really, I don't see much in the way of definitive bridging bony callus. There's still a very distinct fracture gap. Okay. But over time, again, if you give it enough time and now the animal is not using the leg very much, then you'll start to see maybe the callus is starting to bridge a little bit. The fracture line is becoming less distinct. And at this point, 2 months later, that fracture may continue to heal. Okay. It's not perfectly aligned. It's malaligned a little bit. Same with the ulnar fracture. Okay. Not as ideal, but sometimes that can happen with secondary healing. There's other factors that will prevent that from happening. Here's another example. Comminuted fracture of the femur, bunch of pieces in there. This time we put an interlocking nail, but it's got all these little fracture fragments as well. So there's probably a little micromotion. And over time, we start to get this large callus formation that starts to form. So that's fracture is healing in a secondary bone healing method. Same here. As you can see, same kind of situation here. Okay, so what are factors that will determine how fast or even if a fracture will heal? Well, there's lots of things, and most of these, we're going to run through these relatively quickly, but most of them are common sense kind of things. It's kind of intuitive if you think about them. So when the fracture happens to a bone, if it disrupts a lot of the blood supply to those fracture fragments, so you have a lot of vascular trauma, okay, that will affect the ability of that fracture to heal. The more obviously for any fracture to heal, it's got to have blood supply and oxygen and nutrients that are supplied by the blood and the vascular system. If you disrupt the vascular system and it's poorly defined and all traumatic and torn up, then it's going to take a lot longer for that fracture to heal, if it ever will at all. Okay. The location of the fracture will also affect its ability to heal. In a mature dog, mature animal, cat or dog, or a person for that matter, if you remember from anatomy, in the diaphyseal long portion, the shaft of long bones, in the marrow cavity, most of the time in mature animals, there's really not much bone marrow in there. It's a lot of fat. Okay. It's bone marrow fat. Okay. On the other hand, in the metaphyseal region of the long bones, so where they flare out on either end, there's a lot of trabecular bone in there. So that's that spongy-like bone that's got a good blood supply, a lot of blood flow inside of it instead of fat. So because of that and the better blood supply, fractures that happen in the metaphyseal region of a bone will tend to heal a lot faster than diaphyseal fractures because, again, the diaphyseal fractures, there's not much bone in the bone marrow and it's mostly fat. So diaphyseal fractures tend to heal slower than metaphyseal fractures. The big one here is degree of immobilization. Okay, again, if you have two fracture fragments like that and they just even have a little bit of motion when the dog's walking around, it's going to greatly hinder healing of the fracture and you're going to get second intention healing. Ideally, you want rigid fixation where the fracture fragments are right next to each other, and those fracture fragments, no matter what, they don't move in any direction. Okay. The fracture type will also affect it. So the more complicated the fracture, the more comminuted pieces, the more little pieces around the fracture, it's going to take longer to heal. Okay, all this again, most of it's common sense. The degree of post-reduction apposition, that sounds kind of fancy, but all that means is if you go in and you have a fracture and you first see it and it's this far apart, when you surgically try to fix it, if you can get the fracture fragments as close together as possible, it's going to heal faster than if they stay farther apart. Okay, the age of the animal, that makes sense as well. Okay, older animals, older people heal a lot slower than younger animals, so that would make a perfect sense in my mind. The degree of local trauma, same thing. This is kind of the same thing as the vascular integrity. The more trashed the tissue is, the more torn up the soft tissue is around the fracture, it's going to take longer to heal. Same thing, degree of local trauma, same thing. Degree of bone loss. Okay, if you have a whole lot of bone loss in that area, in the fracture itself, and the gap is really compromised, the gap of the fracture site is really large, it's going to take longer to heal. Again, the type of bone involved, that kind of goes along with the diaphyseal versus metaphyseal region. If you have a lot of trabecular type bone marrow in that area of the fracture, maybe it's a young dog where they do have trabecular bone in the diaphyseal portion, it's going to heal faster. Okay, so cortical bone that has fatty like bone marrow, it's going to take longer to heal. Another big one is infection. Okay, if it's a gunshot wound and now there's also an infection in the fracture itself, so now he's got a staph or strep infection in the fracture, it's going to take, it's not that it won't heal, it could heal if treated appropriately, but it's going to take longer to heal. Okay. Also, if there's a tumor in that makes sense. So if it's a pathologic fracture, the bone fracture, because there's underlying cancer in the bone, it's going to take longer to heal if it ever will at all. Another thing that will hinder healing is if the animal is on steroids. If the animal is cushingoid, he's self-medicating with steroids, right? If you give him steroids, okay, if you give him any kind of Vetalog or any kind of corticosteroids like that, that will hinder healing of the fracture and it will take longer. Okay, so what do you look at on x-rays after you go in and you try to fix the fracture? You look at some of these things that we already talked about. How well is the fracture fragments aligned? Okay, if they're aligned like this and it's a long bone, that's great. If they're aligned like this, that's not as good. It may still heal, but it's going to take longer to heal. Okay, the degree of fracture reduction. Okay, ideally, if you have a fracture like this, if it's off a little bit, it'll still heal. But in general, you want at least 50% reduction. So right in here, the fracture fragments would be 100%. Like this, they'd be 50%. Like this, it's going to be little, if maybe 5%. That's going to take longer than if it's at least 50%. Okay. And you want to look at again, when you see a fracture in a long bone, like I said earlier on, you want to always take the x-ray, the radiograph, to where you see the joint above it and you see the joint below it, because you want to make sure there's no little fissure fracture lines that extend proximally or distally and could involve a joint. Anytime the fracture involves a joint space, that's a bad thing. Okay, you want to look for rotation of the fracture fragments, the placement of the fixation devices are this. You don't want to have a cerclage wire, you don't want to have a screw, you don't want to have anything like that right in the fracture itself. You want to have it away from the fracture. So it could be distal to the fracture, the screws could be, or it could be proximal, but you typically don't want to screw right through the middle of a fracture. Okay. Now let's talk about a couple of definitions that you need to know too. So a malunion fracture is a fracture that has healed, but it is healed in an abnormal anatomic position. So if I have a fracture of a long bone like that, and it's healed like this, or it's healed like this, a little bit of bowing one way or the other, but it's healed, that's called a malunion fracture. Okay. A delayed union fracture is an arbitrary thing. That means the fracture is taking longer to heal than you would expect. And usually a delayed union fracture is going to be caused by one of those factors that hinder fracture healing, like a concurrent infection, movement of the fracture fragments. They're not aligned. A big fracture gap may take longer to heal, leading to what's called a delayed union fracture. And then we get to what's called a non-union fracture. And this is a fracture that has stopped even trying to heal. Okay. There's no more attempt to heal. The body's given up. Okay. And that unless you do something surgically, that fracture will never heal. Okay. And this is there's actually two types of non-union fractures. There's one that's called a hypertrophic non-union, and the other one's called an atrophic non-union. Let's take a picture of that. So here's some examples. So this fracture of this femur here has healed, but it's obviously not in normal alignment. And so that would be a malunion fracture. Okay. The dog may run around, he may, not be painful anymore, but obviously, intuitively, you would think, well, now this bone is really at some odd angle. So it's probably going to put abnormal stresses on this side of the distal femur and the stifle joint, and they may lead to chronic degenerative changes or arthritis of the stifle. Okay. A delayed union is a fracture. Again, maybe you got a callus formation, but for whatever reason, it's taking longer than you would expect it to heal. So that's a delayed union, and you can't really diagnose that unless you know how long it's been since the dog fractured the leg. Okay. A non-union. This is an example of a hypertrophic non-union. People will describe this as having an elephant foot appearance, because here's the fracture gap. The fracture gap will never fill in. There's not going to be ever any callus formation, but the adjacent fracture fragments are widened and expanded, kind of like an elephant's foot looks like that. Okay, so that is a hypertrophic. So this is callus formation. At some point in time, the body was trying to heal it by second intention, but for whatever reason, it didn't work, and now the body's given up. Okay, a lot of times the fracture end plates will become smoothly marginated, well-defined. They're sclerotic. They're more white than normal, and that means that bone it's not going to heal ever unless you do something. Okay, so this would be an example of a non-union fracture. This was after a gunshot, and you can see the very large, obvious fracture gap. The bone itself is kind of rounded. It's sclerotic. Okay, there's absolutely no attempt at a callus formation. And that fracture, unless you go in surgically and debride that area, so scrape it around, get to nice bleeding bone again, and then attach these two pieces together with some type of metallic implant, a bone plate or something like that, that ain't never going to heal. Okay, so hypertrophic non-union are ones that have a callus formation, but no bridging bony callus across the fracture gap. It will never heal. Here's an example of that. Here's early on a fracture, and this is that non-union hypertrophic non-union fracture, the way it's going to appear. Okay, an atrophic non-union, same thing. There's no fracture gap. The fracture gap is very apparent, but there's no bridging bony callus. But this time we just get atrophy of the fracture fragments. There's no widened appearance. There's no elephant foot appearance. It's just a fracture that is just kind of atrophied away and is never going to make an attempt to heal. And again, sometimes you can rescue these dogs. The surgeons can go in and put a plate across there. They can put a bone graft in there, debride the fracture fragments. And if you do all that effort, then sometimes that fracture will go ahead and heal. But unless you do something, it never will. Okay. Okay, fracture description. I'm not going to spend a whole lot of time on this. So how do you describe a fracture? And this is kind of the way to play like this is if you're on a telephone call and you don't have the ability for either side, you're looking at a fracture that you saw in your clinic, but you're calling a surgeon and to get advice on how should I fix this or should I send it away, turf it out to a specialist to be fixed. And the surgeon can't see the films. You need to know how well you can describe that fracture so that surgeon on the other end can paint a mental picture and know exactly how that fracture appears. Okay, so typically what you do is here, obviously there's a fracture and you would describe the fracture in certain ways. So first off, you would say this fracture involves the radius and ulna of the left front limb. Okay, all that's true. And then you would say it involves the distal diaphyseal portion of the radius and ulna. And then you would describe, is it comminuted or not? Well, there's some little bitty bony fragments, so you would say it's mildly comminuted. And then you always want to decide if it is involving a joint or not. Okay, and to me, there's no way it's involving a joint here or here, so it is a non-articular fracture. And then you want to describe if there's soft tissue swelling around it. Yeah, there's a moderate amount of soft tissue swelling and maybe a few little gas opacities. So it could be an open fracture with a moderate amount of soft tissue swelling. Okay. And then you want to describe the displacement of the fracture fragments. So how close are they to being in an anatomic alignment? How far apart are they? And you always want to do that in relation of the distal fracture fragments in respect to the proximal fracture fragments. So in this case, you would say that in this case, the distal fracture fragment, this part of the radius and ulna, are caudally displaced with respect to the proximal fracture fragments. On the other view, you can say that the distal fracture fragment here is now cranially displaced with respect to the proximal fracture fragments. Okay, so if you describe it as in detail as possible, like that, this is a transverse, mildly comminuted, non-articular fracture involving the distal diaphyseal portion of the left radius and ulna with a moderate amount of soft tissue swelling, maybe a few little gas opacities, with moderate cranial caudal displacement, and a few little fracture fragments in there. That would paint a nice mental picture for the surgeon. Oh yeah, I kind of visualize how that's going to be, and that will help the surgeon to help you decide what's the best way to fix it. Okay, so you describe the displacement of the distal fracture fragment with respect to the proximal aspect of the bone. Okay, now we've kind of covered general orthopedic stuff and radiology, and now we're going to talk about specific bone diseases, kind of like we did with neurology. We're going to kind of go through them one at a time as we talk about them. Okay. The first one we're going to talk about and the first group is called developmental bone disease. So this is abnormalities, skeletal abnormalities that happen in young growing dogs. And for the most part, these will occur in dogs less than about 10 to 12 months of age, so skeletally immature dogs. And for the most part, they only happen in large breed dogs. So why that is, I don't really know, but a lot of those large breed dogs are fast growing when they're puppies. And a lot of times because of their breed, some owners, they think, well, we need to grow them up fast. Let's get them as big as we can, all that. So they feed them really hot diets that have a high caloric intake, a lot of probably too much calories than they really need. And that can lead to some of these abnormalities, these developmental orthopedic issues. On the other hand, some of them are also hereditary. So if the genes pass down for osteochondrosis, then that dog, the puppies will probably be more prone to osteochondrosis as well. So the first one we're going to talk about is just that, osteochondrosis. Okay. You may have heard about it before, but we'll talk a little bit about what it is, what causes it, and how do you recognize it on radiographs, and then what can you do about it? Okay, so osteochondrosis is really a dysfunction of endochondral ossification. So if you look at the distal end, the epiphyseal portion, the articular surface of a long bone, okay, normally it's covered with hyaline cartilage. It's got a little glistening covering like a cap on the distal end of the bone. That's the part in the joint space that's covered with this little bit of cartilage. But the bone right underneath that in a young growing dog has a bunch of osteoblasts in that part of the bone that normally those osteoblasts are soft. They're kind of cartilaginous. They're kind of weak, spongy like bone. But over time, they tend to make the bone longer by ossifying. So they turn into mineralized bone tissue. And that because of that, over time, the bone tends to increase in length. That's called growing. Okay. So that's what happens in the subchondral, just underneath the cartilaginous portion of a long bone within the joint. Okay. Any issue in those osteoblasts right underneath that cartilaginous cap of a long bone can lead to disturbance in growth. Okay. So anything like, for example, let's say that you have poor blood supply in the joint space itself. Normally, the epiphyseal portion of the bone gets some of its blood supply and nutrients from the joint fluid itself. So if that cartilaginous cap on that bone, instead of being pencil thin, it becomes thickened, then it's harder for nutrients and oxygen and glucose to go across into the bone. And so now we have those osteoblasts that don't get the nutrients and blood supply they're supposed to, and they die. Okay. Well, that will lead to soft, spongy bone that the body tries to heal, but usually has pretty sad luck in healing that. So it leads to weak cartilage, little focal area of the joint itself, that in the epiphyseal portion of the bone, that's soft. It's spongy. If you could poke it with a little poker, a little metallic poking device, then it would, you could feel it. It actually indents. It's soft. Well, as the dog moves around and he moves his joints around and things like that, because of that little focal area of soft bone, sometimes it'll break off. And then you have this flap of cartilage that broke off from the epiphyseal surface of the bone, and that cartilage floats around inside the joint. Okay. Well, what does the body do with soft tissues as it tries to heal it? It turns it into mineralized stone. Okay. So now first off, you get this little flap of cartilage that breaks off from the soft bone in the epiphyseal portion. This little thing of cartilage, maybe 2 millimeters big, starts to float around the joints, bathed by all this nice synovial fluid. And over time, it turns into mineralized tissue. And that results in a mineralized foreign object, if you will, inside the joint itself, that when the body moves around, it's painful. Okay? So here's, again, this picture freaks me out because it's in color, and I don't know anything about this. But anyway, so these are the little osteoblasts that form in here. So if you disrupt anything, you cause any kind of damage, infection, or trauma or anything, these osteoblasts can get damaged and then they quit growing, and that results in soft bone, and then it can break off and you get this cartilaginous thing that flows along inside the joint space. Okay, so osteochondrosis, where does it happen? It's a disease condition. This is super common. You'll see it a lot, especially in large breed young dogs, of course. And it happens in certain specific areas of different joints. The most common one that you will see it in is in the shoulder joint. And specifically, it happens in the caudal aspect of the humeral head of the shoulder, by far most commonly. Okay, so what do we see? These dogs, again, they're large breed dogs. They're young. They come in, they have moderate front limb lameness, maybe on one side, maybe on both sides. Usually after they start running around a little bit, the pain's even worse, and they got shoulder pain. Okay, so if you look here, this is our shoulder joint. So this is the scapula, this is the humeral head. And we said the most common spot for osteochondrosis in all dogs and everywhere is the shoulder joint. But the most common portion specifically of the shoulder, it happens on the caudal aspect of the humeral head. Okay, and what do you see? The commonality, the common thing that you see radiographically with all osteochondrosis lesions, no matter where they're located, is you see this, a concave divot out of the bone. Normally the humeral head should be shaped like this, should be nice and smooth, and go all the way down here and be nice and smooth, but it looks like somebody took a bite out of it. It looks like there's a little concavity, a little focal radiolucency associated with the caudal aspect of the humeral head. Okay, sometimes it appears just very mildly flattened. Okay, but that's what you see with osteochondrosis, and the caudal aspect of the humeral head is the most common lesion. Okay, and why do you see that? Well, that's because that part of the subchondral bone and the cartilage is soft and it's broken out. Okay, so there's a good chance that somewhere in this shoulder joint, there's a piece of cartilage that's floating around inside this shoulder joint. Now, given time, that little piece of cartilage can turn into bone, and then you'll see it radiographically. Sometimes it just resorbs by itself, but you're still left with this lucent lesion on the caudal aspect of the humeral head. Because of that lucent lesion, now that's abnormal. It makes that joint a little bit more unstable, and you'll start to get over time a lot of arthritis that starts to form around the joint. Okay, so look for the the concavity, this lucent lesion where it looks like you took a little bite out of the bone. That is osteochondrosis. In this particular case, the most common spot is the caudal aspect of the humeral head. Okay, here's another lesion here. So this is a different dog. Obviously, there's an obvious concavity, this lucent area on the caudal aspect of the humeral head. And if you look real close, there's these little mineralized fragments. So that's where the cartilage has already broken off and is starting to mineralize. Okay. And I'll give you this tip too, that, and this is in the medical literature. So a mineralized intracapsular in the joint space opacity is called a, does anybody know the name that people call these inside a joint? It's called a joint mouse. Okay, and that's in the literature, even the human literature, they call them joint mice. Okay, so this animal has several mineralized joint mice inside the joint. And I kid you not, also in the literature, that if these are really small, they tend to call them joint mice. If they're somewhat big, they call them joint rats. And if they're huge, they call them joint cats. Okay, that's very commonly known in the medical literature. So now you've been introduced to that terminology. If you leave it alone and don't do anything about it, then over time that area will fill in with bone. It's not normal bone, but it will fill in, but you get a lot of arthritis. Now you start to get mineralized opacities on the infraglenoid tubercle, large bulbous mineralized opacities on the distal end of the caudal humeral head. You get mineralized opacities up in this area. You can get a lot of arthritis or degenerative joint disease is probably a better name for osteoarthritis that you see all the way around that joint. Okay. So what do you do about this? Okay. We know that osteochondrosis, no matter where it's located, is very common in large breed, fast growing dogs. And unfortunately, we also know that some of it is nutrition related. Okay. And a lot of these dogs that come in that have osteochondrosis lesions question the owner, they'll have these dogs on really high caloric puppy like diets because they think it's good to have them grow big as fast as they can and get them big as they can. So, one of the first things you want to do is cut the diet. You want to take them off puppy diets. And if you look, some of the hills and some of the, even some Purina and stuff like that now, they have changed the puppy diets, the puppy food, the puppy chow, or whatever you want to call it. And they have specific ones for large breed diet. Okay. For large breed puppies. And all they really done in that is they've cut the caloric content. Okay. Because we know that a high caloric content will predispose a large, fast growing dog for osteochondrosis. So first thing you want to do is say, what are you feeding them? And let's, instead of feeding them a puppy diet, let's feed them regular adult dog food with less calories. Okay. The other thing that you can do if you catch it early on, a surgeon could go in with an arthroscope, which means they make a little stab incision and they put a little device in the joint itself and they can look around. Okay. And then they can make another stab incision at another angle. And once they find the joint mice and the little cartilaginous area of soft bone, they can clean the joint out. They can basically remove any joint mice that's in there, any mineralized fragments. They kind of vacuum them out and get rid of them. And then the lesion itself, they'll go in with a very miniature little ice cream scooper like device, the metallic thing, and they scoop out all this soft cartilage, get down to bleeding bone, and then that bone will then fill in and try to heal itself. Okay. So that's the best way to fix osteochondrosis is you go in arthroscopically and you clean the joint out. Okay. Unfortunately, even if you do that, a lot of those dogs will still develop degenerative joint disease, but it may not be as severe. Okay, where else can you get osteochondrosis? Again, the common lesion is you look for a focal area of lucency in a normal bone that is, it doesn't have that normal, well-defined appearance. So elbow, it can also happen in the elbow. Here, I'll ask you this. What's the most common site of osteochondrosis in a young, large breed dog? And what you should say on a test is the caudal aspect of the humeral head. You shouldn't say elbow. You shouldn't say hock. You shouldn't say stifle. You shouldn't say cranial aspect of the elbow. It's on the caudal aspect of the humeral head in the shoulder. Okay. So now we're going to talk about other places osteochondrosis can happen in. It can also happen in the elbow joint. And again, large breed, the common thing, they're all large breed young dogs. So where does it happen in the elbow joint? Typically, you get the concave lesion right here. It usually happens on the medial or the distal aspect of the humeral condyles. So you can see here's a radiograph. Same thing. You get this lucent lesion and maybe some flattening right here on the distal aspect of the humeral, condyles, whether it's medial or lateral. It can happen on either side. Okay. And again, you can arthroscopically go in, try to clean that out, clean out the joint, get rid of any mineralized or cartilaginous fragments floating around in the joint. If you don't do anything, the dog will start to get osteoarthritis or degenerative joint disease. This dog already is getting it. Okay, so here's another very subtle lucent lesion, but you can also appreciate it's a little flattened here, maybe a little concavity along with that subchondral lucency. Okay, and the other thing that I will tell you again, it's a common thing, is that unless you shoot really good quality radiographs that are exposed properly, you'll miss these lesions. Okay. So you have to shoot good films with proper positioning or you're going to miss them. Here's another one. So flattened area over here, it's kind of irregular in shape. We get this lucency right in the subchondral region. That's a typical osteochondrosis lesion. These little irregular areas of the bone right in here, this is the start of degenerative joint disease or osteoarthritis or osteoarthrosis, all the same stuff. Okay, so this is the body's attempt. Let's put bone around this joint because something's wrong with it, and let's put bone around it. So these are actually called osteophytes, is the real name for these. An osteophyte, they're usually called periarticular, meaning around the joint, osteophytes. This is a little spiculation of bone that forms here and even some down in here. And these are typical that you're going to see with arthritis going forward, osteophytes. Okay, so now we talked about osteochondrosis can occur in the shoulder, specifically the caudal aspect of the humeral head, which is the most common one. We also talked about it can happen in the elbow joints, usually on the distal articular surface of the humeral condyles, whether it be the medial humeral condyle or the lateral humeral condyle. And now we're going to talk about osteochondrosis can also happen in a stifle joint. Okay, where does it happen in the stifle joint? Typically, it happens on the femoral condyles. Okay, so again, you're going to look for an area of flattening in a young, fast-growing dog or a concavity in that part of the bone. It can happen on the medial femoral condyle, or it can happen on the lateral femoral condyle. Okay. So here's an example. You can barely see it here. There's a little lucency here, but you can easily see it right in here. This lucent area is that medial or lateral? Where there's the fibula, so it's got to be lateral. So now we got a lucent lesion with some flattening involving the lateral femoral condyle, typical of an osteochondrosis lesion. He's also got, because of this, he's got a lot of swelling and effusion within the joint itself. So all of this is increased synovial fluid inside the joint because the joint is pissed off because there's something wrong with it. Okay, and you get all this effusion inside the joint. Some of it may be a little bit of hemorrhage in there too. Okay, so osteochondrosis, again, of the stifle joint usually happens on the articular surface of the distal aspect of the femur, whether it's the medial aspect or the lateral aspect. Okay, another example, this one here, you can see kind of end on this lucency that you can see here. Here's another example right in here. Okay, so this is another stifle joint. He's got a little osteochondrosis right in here. He's got some degenerative changes. So these are osteophytes or arthritis starting to form on the trochlear ridges of the distal femur. But he's also got a lot of effusion inside the joint space. That's too much synovial fluid, which we'll talk more about that when we talk about cranial cruciate disease coming up. Okay, let's go to this one. So another spot that you can see osteochondrosis is going to be the tibial tarsal joint, otherwise known as the hock joint to us veterinarians, right? So again, signament's the same, young, large breed growing dogs. This happens really commonly in Rottweilers and Labradors in this location. I don't know why, but it does. So what do you see here? This one's, it's the same game, but it's a little bit different. So if you look at a normal dog over here, and this is a little diagram of a normal dog, remember this is the distal end of the tibia, okay? This bone that's sitting right in here, this kind of square looking thing right in here, that's the talus. The other bone, this big here, that's sitting right next to it, and they hook together, is called the calcaneus, okay? But for osteochondrosis, really what we're worried about is the talus. And specifically, we're worried about the medial and lateral trochlear ridges of the talus. It should have two little peaks, okay? This is the lateral aspect over here. So this is the medial trochlear ridge of the talus, and you get this little well-defined peak, okay? And then you come over here and you get a little broader peak, but it's still a well-defined peak. That's the lateral trochlear ridge of the talus, okay? And from a lateral perspective, they're kind of superimposed, but you should get this rounded area in here. And the joint space in a normal dog should be congruent. In other words, this joint space is, number one, it's well-defined. Number two, it's the same width if you write it all the way from medial to lateral. It's the same width. It's a congruent, nice, well-defined joint space. Well, osteochondrosis, that happens in the tibial tarsal region or the hock, usually what happens is one of these trochlear ridges here of either the medial trochlear ridge of the talus or the lateral trochlear ridge of the talus is soft and it breaks off. Okay, so you can tell if right here, if this part that is normal here, if that doesn't form right, is soft and breaks off, then this part here is going to be flattened. And because of that, it's going to like this. And that joint space now is going to be widened in appearance, focally right over that area. Okay, so it can happen either here on the medial trochlear ridge of the talus. Here I don't see it. This dog has osteochondrosis, and secondarily, a widened appearing joint space. Or it can happen over here on the lateral trochlear ridge of the talus. This bump here could break off. And now that part of the joint would be widened in appearance, and this part would be flattened. Either way, that's osteochondrosis of the talus. So here's an example. So which side's lateral? Well, you know, because there's the fibula. Also, the calcaneus is always lateral. So this is lateral, this is medial. Okay. And if you look here, if you kind of look through here, that joint space looks congruent over here, but I come over here and it's widened in appearance. And this little medial trochlear ridge of the talus here is kind of ill-defined and irregular in shape, probably a little joint mouse right in here. So that is typical of osteochondrosis of the tibial tarsal joint or the talus. In this case, it's involving the medial trochlear ridge of the talus. Okay, here's another example. So here, now I can read through that calcaneus, this side here, the lateral trochlear ridge of the talus, and that joint space looks nice, it's congruent. But I come over here and now it's widened in appearance and I get this little focal concavity associated with the medial trochlear ridge of the talus, osteochondrosis. Okay. This one's kind of a weird one here, and you can do a special view, but you can actually see the lesion here. In this case, now it's on the distal end of the tibia on the lateral aspect. So now I got this subchondral bone defect right in here. And again, that's another example of a little bit of a odd placed osteochondrosis lesion. Okay, so here's another example. So look at this. This is a normal view. This is called a flexed AP view. You don't need to worry about it, but here's a flexed AP view. So here's lateral, there's the fibula. And look at this joint space. This is the lateral trochlear ridge of the talus. This is the medial trochlear ridge of the talus. The joint space is very pretty. It's very nice. It's congruent, same width all the way around it, as opposed to the other leg on this side. So here's lateral, here's medial, but now look at this widened aspect of the joint space. It doesn't look like that at all. And that's because this part of the medial trochlear ridge of the talus broke off and is not there. It fragmented away. Okay, it's not really fractured. Okay, it just never did form right and it disintegrated. Okay, so it just, you know, kind of fell apart. Okay, so that's a typical osteochondrosis lesion. And again, in the tibial tarsal region of the hock, super common for whatever reason in Rottweilers and Labradors. Okay, so as a review, where's the most common spot to get osteochondrosis in a young dog? And the most common spot, you're going to say, number one, the shoulder. But I'm going to want you, when you get to your 4th year in your clinical year, and you're in surgery or you're in orthopedics and or radiology, and the clinician, if they're worth their weight in salt, they're going to say, yeah, I know the shoulder. Be more specific. And that's when you're going to say, exactly, the caudal aspect of the humeral head. That's where the most common spot is in the shoulder of a young dog, large breed dog. Okay, but osteochondrosis can also happen on the medial or lateral condyles of the distal femur. It can happen on the medial condyle of the distal humerus or lateral condyle. Rarely it will happen on the distal aspect of the fibula. Just like we talked about, it can happen on the medial or lateral condyles of the trochlear ridges of the talus. And sometimes it happens on the scapula near the shoulder, but that's pretty rare. Okay, so I'm thinking about it, and I remember this from when I was in vet school. I remember, I think, in when we were taking orthopedics, that class, I remember the question that I got, which I don't remember if I got right or not, probably not, but on the test said, which of the following joints does osteochondrosis typically not occur in? Okay, well, which joint, you know, the common joints do I see here that it doesn't occur in? And the thing that doesn't occur in, you hardly ever see it in the carpus. Okay, so that was the answer. It said, I think it said shoulder, it said elbow, it said, you know, or tibial tarsal region, or the carpus. Well, it doesn't happen in the carpus, but it can happen in all the other ones. Okay, So now we're moving along from osteochondrosis, and we're going to talk about another developmental orthopedic disease. And this one's called a fragmented medial coronoid process. People in veterinary medicine and all medicine love acronyms, so you'll see it abbreviated as FCP, fragmented coronoid process. But you've noticed a couple words here. Number one is the medial coronoid process. We're going to review the anatomy here in just a minute. There's also a lateral coronoid process. The lateral coronoid process never poses a problem. It's always the medial one. Okay. And also notice this word, fragmented. It's not fractured. There is no such thing as a fractured medial coronoid process, although a lot of veterinarians call it that. Okay, it is a fragmented, and it's the same thing as the osteochondrosis lesion. In fact, a lot of people think fragmented medial coronoid disease is a form of osteochondrosis. So it's a little ridge of bone, just like in the talus, that doesn't form right and it breaks off. It's not fractured due to trauma, it just disintegrates or fragments. Okay. So let's review the anatomy and then we're going to take a break. So here's a lateral view of a dog's elbow. So here's the humerus, here's the humeral condyles right in here. Okay. This little squared off part of the humerus is the medial epicondyle of the humerus. Okay. This is the ulna. Obviously, that's the radius. Okay. That's the radial head that comes up in this area right in here. Well, the ulna is the thing that we have to look at, and we have to look at all the funky ridges and everything of the ulna. So first off, this bump at the back end of the ulna is called the olecranon. Okay, I remember when I was in freshman year of vet school in anatomy, and I sat next to a guy that he always called this the olecranon. Okay, so you always want to try to pronounce them right so you sound halfway intelligent. So it's not the olecranon, it's the olecranon. Okay. So this little swooping area right in here is called the anconeal process or the anconeus. Okay. And that's part of the ulna. Okay. And then we get to these little ridges over here. This big one, the medial one and the major one, you can remember that because M starts with medial and major. So the big swooping ridge is this line of the ulna right in here. And it has to look just like this and be well defined. So you trace in this part of the ulna, it comes up here, and it forms like this well-defined ski tip looking thing. Okay. And it has to be well-defined and a ski tip, a nice little point on it. Okay. That is the medial coronoid process. That's the one that causes the problem. Okay. The lateral coronoid process is this line. Okay. That's the one that never causes a problem, so you don't have to worry about it. You will never cause a problem, never have to worry about the lateral coronoid disease. It's always the medial coronoid process, which is this line, and it has to have this well-defined ski tip appearance. Okay. So now that we have reviewed the anatomy, let's take a break, and then we're going to talk about fragmented medial coronoid processes. All right. I will see you guys in 10.